by Dr. Prithvi. Next, I call upon Dr. Shishir. He'll be talking about hemorrhages and exudate, diabetic retinopathy, or a diagnostic decoy. Over to you, Dr. Shishir.
Yeah, thank you, Doctor. So good morning, everyone. So my talk is on mimickers of diabetic retinopathy, and sometimes when DR comes to your clinic or some patients are referred to you as diabetic retinopathy for treatment, sometimes it's not exactly what it seems to be. So let's go on and see some cases. So this is a 50-year-old male diabetic hypertension CKD. You can see this is how they're usually present in the late stage with these chronic hard exudates, like a cluster of CSME in both eyes. So this is like a classic diabetic retinopathy in what you see, but now you're going to see some which present like this, but they're exactly not diabetic retinopathy. So this was a case, 57-year-old female, mild decreased vision in the right eye, diabetic hypertensive on medicines. Both eyes had mild NPDR. She had 6/9 vision in the right eye. Now, if you look at this fundus picture, you can see some exudation in that region, nasal to the optic disc, and there is also some like microaneurysm and some few hemorrhages, what you see there. But when you actually do the OCT, you can see there is a double layer sign with a small polypoidal lesion, but you see along with some hard exudates there. So this was basically polypoidal choroidal vasculopathy, a subtle one. And then when you do the OCT angiography, you can see this nice network just seen nasal to the disc in this patient. So this was not my moderate NPDR. This was referred as moderate NPDR, but this was actually PCV. And then you also on this other OCT, the deep slab, you can see this nice branched vascular network, what you see. And then post anti-VEGF and a shot of focal laser, patient improved back to 6/6 vision. So let's go to another case. This is case 2, proliferative diabetic retinopathy patient, 62-year-old male, DM, HT and CKD on a wheelchair, on dialysis 3 times a week. So he had 6/9 vision in both eyes. So in the right eye, you can see the classic changes of diabetic retinopathy, hard exudates, these hemorrhages, and also you can see some sclerosed vessels inferiorly. And in the left eye, those features are also there, but along with that, there is also a submacular or para submacular hemorrhage, what you can see, and like a small bump. So when we did the OCT through the fovea had subretinal fluid, and when you did the OCT through that bump or that area of the hemorrhage, you can see this small polypoidal lesion, what you see. So this was PDR. Along with that, patient had a PCV also in the left eye. So here the highlight is the OCT should not just be done through the fovea, but it should also be done along the full arcade. So you should get a raster scan, then only you will know exactly what is happening. And then this is post treatment with ILIA and a shot of focal laser to this extramacular PCV. You can see the SRF is gone. There is some non-center involving DME which is there, and this polyp has kind of scarred now. This is 4 months post treatment, and also along with that, he has undergone 3 sittings of panretinal photocoagulation in both eyes, what you can see in this wide field photograph. So let's go to the third case. So this was also again a patient, 55-year-old male, diabetic hypertensive, on dialysis twice a week. And you can see he also was referred for panretinal photocoagulation 3 sittings, and also advised anti-VEGF steroid injections because the nephrologist refused for giving a consent for the anti-VEGF. So he had referred to as DME with PDR in both eyes. So this is how it looks. Looks like CSME, these yellowish spots there at the fovea there. And here also left eye also has these kind of yellowish kind of also fluid there in the left eye too. So this is the peripheral picture, looks like a diabetic retinopathy, all hemorrhages, exudates. But when you do the OCT, you see this picture in the right eye, which looks like this long subretinal fluid along with precipitates in the subretinal space. This whitish color, what you see as subretinal precipitates along with, large amount of shallow fluid. This is in the right eye, and in the left eye, you see this like a DME fluid, but along with that, a large amount of subretinal fluid. So this did not look CSME or a DME to me. So I did the FFA. Now, when you do the FFA of the right eye, you can see there is a ink blot leak just away from the macula there. So this was actually a chronic central serous retinopathy along with a diabetic retinopathy or a PDR. And when you do the FFA of the left eye, you really don't see any leakage. If it was a DME, you would have had these dense leakage occurring right at the center there. But here you don't see much of a leakage. But in fact, you have an NV happening On top there you can see this new vessel there. So this was PDR coexisting along with a central serous retinopathy, and he was treated with 3 sittings of PRP along with focal laser in the right eye and micropulse laser in the left eye, because there was no real point of leakage in the left eye. Anti-VEGF and steroid was not given in this patient. So let's go to case 4. So this was a 70-year-old male diabetic, female diabetic. Right eye was post vitrectomy for PDR with vitreous hemorrhage, and the vision in the right eye was 618, the left eye was 69. So here you can see this dense, again hard exudates there coming close to the fovea, what you see, and also in the left eye there is some amount of exudates along with hemorrhages, and both eyes were treated with 3 sittings of panretinal photocoagulation, and on top of the right eye was also post vitrectomy. But when you do, so she came with complaint of blurring in the right eye, and I thought it's probably a post vitrectomy DME, or the still DME is due to the diabetic retinopathy. But when you did the OCT, you can see she also has a shallow bump, that double air sign on what you see, and along with the in the parafoveal region, she's got these exudates. So along with a PDR, she was also having a age-related macular degeneration, or a type 1 macular neovascularization, or a network there. So, and when you do the OCT, you can see this huge chronic large new vessel, which what you can see in the right eye over there, and she was treated with anti-VEGF injections. So let's another case, 50-year-old female diabetic, obese lady, 66, 6 by 6 parts vision, both eyes, referred for moderate NPDR in both eyes. So you can see this lot of cotton wool spots all along the arcades, and also nasal to the macula there in the right eye, and then she's got a large cotton wool spot just close to the fovea in the left eye. Now when I dug down and asked the history, she had a history of snoring in the sleep, and also waking up multiple times at night after sleeping. And this was the OCT in the right eye, no fluid, but you can see that cotton wool spot on the OCT there in the right eye, and another large one corresponding to the fundus photo in the left eye. So this was actually a retinal microvascular damage due to obstructive sleep apnea. So the obstructive sleep apnea can mimic diabetic retinopathy, presents with hemorrhages, cotton wool spots, sometimes dilated and tortuous veins, disc edema can be there, and also you can exacerbate if there is a diabetic retinopathy, can exacerbate the diabetic retinopathy too. So another case, a 50-year-old female, she came for a routine examination, 6 by 6 vision, both eyes. Somebody referred saying right eye has moderate NPDR, and sent the patient. So she is diabetic, and she also has mild NPDR in both eyes. You can see the few hemorrhages there in the left eye. The right eye also has hemorrhages and some exudates. But you can see this small bump over there, and when you do the OCT, you can see this small aneurysmal type lesion, what you see there. So she was actually referred for an anti-VEGF. There was no fluid. So here this is like a ram, like a mini ram or a mini aneurysm. Sometimes can occur in diabetic patients. The small kind of aneurysms can be seen. And the treatment, if fluid is there, you can give anti-VEGF. With no fluid, along with the patient's this thing consent, you can go and do a small focal laser to this mini aneurysm. So the last case, 60-year-old male, diabetic hypertensive, right eye was 6/6 vision, left eye had counting fingers 3 meters. Again sent for CSME. So you can see the exudates at the macula in the left eye, along with the sclerosed vessel there. So the hypertensive changes are seen, along with that moderate NPDR changes are also seen. But when you do this OCT, he doesn't have features of diabetic edema. Instead, he's got the subretinal fluid with these precipitates of what you see. So this looked like uveitic to me, and when I did the workup, he was VDRL and TPHA positive. So this was a syphilitic placoid retinitis. So just finishing up. So some few of the mentions which I have not mentioned here, the common ones which you read in your books are hypertensive retinopathy, tributary vein occlusions, PVAC, radiation retinopathy, blood dyscrasias. These can all mimic diabetic retinopathy. Now, since I showed you that mini aneurysm, I'll just show you a PVAC too. This is how it looks. The PVAC. This is usually occurs in diabetics, or they may not be also having diabetic. They usually present with these small aneurysms of unknown cause, and they show usually a poor response to anti-VEGF and steroid. So the learnings are, you should be aware of the mimickers of diabetic retinopathy, DME, and aware of coexisting disease. So imaging as well as digging down the history is extremely important, and then treatment will be as appropriate. Thank you.